Ready? Say when. Go? Go. All right. All right, good afternoon, everybody, and welcome to our multi-modality imaging conference. Today, we're going to talk about evaluation of the left ventricle by echocardiography, which is one of the main reasons we order echoes on our daily practice, is to assess the left ventricle. And in terms of different parameters that we assess, ejection fraction has been the one that have kind of stood the test of time for over 5 decades. It's a parameter that most people want to know when managing patients. Now, in this talk, what we're going to do, we're going to talk a little bit about a couple of imaging tips and assessment tips, and then how we do LV chamber dimensions, volumes, and ejection fraction. Address the real elephant in the room, which for echocardiography is foreshortening. And then we'll talk a little bit about three-dimensional techniques and finish up with left ventricular strain. A lot of the things we're going to talk about are in the documents by the American Society of Echo. This is one that was very important on the recommendations for measurements of chamber sizes and so on. And in that document, they talk about left ventricular dimensions because it's still one of the common ways we talk about left ventricular size. And in this picture, you see an end mode and a 2D. And basically, the take-home message is that if you have an absolute perfect end mode where the left ventricle is perpendicular to the sound wave, then you have a very nice quality image. The end mode dimensions are quite reliable. The problem is that that is very seldom the case. Quite often, the hearts are angulated, as you see here. And if you do an end mode, as shown with the yellow line, that end mode will give you a bigger dimension than the real dimension, which is one that is perpendicular to the long axis of the LV. So most of the time, we do the measurements by 2D echo, about 1 centimeter at the tips or 1 centimeter below the tips of the mitral valve, perpendicular to the long axis of the LV. And we do the diastolic and systolic dimensions. And of course, we do the wall thicknesses of the septum and posterior wall, from which LV mass also can be calculated with the simple formula that was published about 100 years ago. I don't think Dr. Sabi was even a fellow when that formula came out. We're not going to talk about that formula today. It does have a few sources of errors, but it's what is used most of the time these days. This is an important slide, and most people have this in their labs. It's just to recognize the size of the left ventricle for both men and women depends on body size. So that if you have a true Texan, which is a BSA of 2.3, 2.4, you can easily have diastolic dimensions over 6 centimeters, and there still would be upper limit of normal. Likewise, for some ladies that are large in size, 5.7, 5.8 could still be an upper limit of normal. So it's very important we keep body size in mind when we're looking at left ventricular dimensions. And the same thing, of course, is for left ventricular volumes. So these are two extremes. On the left side, perfectly normal. Even a child would recognize that. On the other side is a really big, bad ventricle. So at the extremes, it's very easy to recognize and to do an estimate of the fact that one is perfectly normal and one is not. The problem is that a lot of function is in between. So you see these are two cases. These are one patient, and this is a second patient. And I'll let you do your own estimates and see what you think the EF might be by estimation. How do we estimate? Well, we train the eye to give us sort of a relative percent change in area change from diastole to systole. You could imagine a bunch of diameters here, and you could do a percent change of what you think those diameters are doing from diastole to systole. Likewise, with the short axis. Very importantly, with a healthy heart, the long axis shortens and the base of the heart descends nicely. And if you have reduction in that, as you have in these two cases, that usually implies some element of reduced left ventricular function. So I can tell you that These two patients, by quantitative techniques, had EF. This one was about 41%, and this was around 44%, okay? But the interesting thing is that these type of cases, when we have shown them in courses where people have audience response system, you get this type of spread. Obviously, the 60s and 20s are basically way out. They really needed a big-time course here. But you see that there's a big spread between the 30s and the 50s. So, it's just too wide for comfort. And the fact is that estimation of EF is something that really requires a lot of practice. And even ourselves, who consider ourselves experts, we have times when we actually do also have a wider range than we would like. So that takes us to measurements. And that's why the American Society of Echoes document have been pushing for us to do more measurements of left ventricular volumes. And to this day, if you're going to do it the manual way, the best technique is the multiple method of DISC, which is a sort of an adaptation of Simpson's rule. So what happens is you trace the heart, and then if you have only one plane, the lung axis gets divided in multiple areas, and little discs are created, and the volume of each of these discs is calculated, and then they're added up. Preferably, you have a two-chamber, then it uses both dimensions. Like, for example, right here, it would use this area plus that area to create the area of that little disc. And then the same thing for every single one of them. It adds them all up and then gives you volumes in diastole and systole. You can see the formula. We will not ask you to memorize it, and I can tell you the ASC exam will not ask you to know that formula either. And it would be impossible, or it would take you one day to do one case manually. But computers love numbers and formulas. So this happens very quickly when you do it in the system. Now, so therefore, the trick is not the mathematics. The trick is how to trace. And this is an example from our lab. We have learned, as I'll show you later, from comparisons with MRI, that in the past, we used to trace a little bit too small by going through all these endocardial borders. And now we have learned to go a little bit farther away and exclude all of these echoes here. And that gives us numbers that are a little closer to the other standards like CMR. We don't use this often, but actually the ASC document mentions that there's a backup for whenever you don't have proper apical views to do a good biplane volume. It's called the bullet formula. And if you look at a bullet, the volume of a bullet is 5/6 times the area of the bullet times the long axis. So it's a very simple thing, because you take a short axis view, you get the area, and you multiply that area times the long axis, whichever longest long axis you get in either a 4-chamber or a 2-chamber. And that gives you a volume, and you do the same thing for diastole and systole, and you can get volumes and EF. Now, obviously, because you're using the short axis area at the level of the papillary muscles, this works better when the ventricle is equally good, equally bad. But the more regional wall motion that you introduce, this method is going to have problems, because it cannot recognize, for example, a dyskinetic apex or a significantly akinetic inferoposterior wall. So it's better when you have diffuse hypokinesis or just normal wall motion. One important recommendation is to get some internal control. And the best internal control in the absence of mitral regurg is the Doppler stroke volume. So your 2D stroke volume and your Doppler stroke volume should be relatively similar. You have 75 and 80, you're okay. 75 and 71, you're okay. You have 75 and 42, that's not okay. So it gives you a way to have an internal control to see if your numbers are making sense. This is a table that most labs have somewhere in the wall, because it gives you the normal range and what is considered mild, moderately, or severely abnormal. But if you remember, I showed you that slide before, that you have to keep the body size in mind. And therefore, if you see here, severely abnormal is called greater than 6.8, and a mildly abnormal would be 5.9 to 6.3, but if you have a very big fellow, that might not be the case. And that's why they also published information for diameters corrected for body surface area. So for example, a severely abnormal would be more than 3.6 centimeters per meter square, which means that if you have one of those 2.1, 2.2 big guys that we have in Texas, we're talking of LV diastolic dimension way over 7. So again, keep body size in mind when you're looking at echoes and making those decisions of mild, moderate, severe. I think I've shown you this slide many times before. You know, if we look at this heart, what is the F? I think most of us probably would say, well, it looks like it's at least 50, if not better. You know, it's contracting, the area change looks good. However, right there, I think most of us would say, that's a bad EF. And it's the same heart. You can see the EKG, same EKG, and they're done basically a few seconds apart by replacing the transducer. So this is a very nice example of the elephant in the room for shortening. And that is really the Achilles tendon of echocardiography for every chamber, not just LV, RV, LA, RA. Every chamber can be foreshortened, and you can have, therefore, errors produced both in determining size as well as determining function. So when you are doing a tomographic cut through the LV, you ideally like to be going right through the equator, right through the center of that cavity. And that would give you something closer to this. If you go off to the sides, now you're making the heart smaller, and the same degree of wall motion now relatively looks like a much better shortening fraction because they are closer together, and then you get something like this. Now, in addition, the other place for shortening is very common is the apical views, because you would like to have the transducer right at the apex of the LV. But the apex of the LV, and this is important for the sonographers in the room, the apex of the LV is not the apical impulse that you feel in a patient. That is more of the distal RV. So that's why you all have been trained to bring the transducer further down once you feel the apical impulse, because as you go further down, you get closer to the apex. How do you know that you're close to the apex? If your first chamber and two chambers apices are both pointing up, and this one is not even perfect, but the closer they are to both pointing up, you know you are at the apex. However, if you get that, if you get what looks like an apex in the fourth chamber, but then in the two chamber, the apex is way out going on the side, you know that you are not. And therefore, the apex you see in the fourth chamber is a pseudo apex. It's not a real apex. And you can see that this cavity looks a lot smaller than here. So that's an important one, because that happens a lot, particularly when we are doing portable studies. The other problem is if you have a lot of translation, like for example, after surgery or somebody's hyperventilating, that heart is moving. So in diastole, you might be perfectly aligned, but in systole, you're not. And that one is tough to correct. I mean, the only thing we can do with that one is recognize it as a reader, but it's very hard to do anything because it's what the patient is doing. So the trick is to pay attention, guys, when you're looking at a ventricle in the short axis view, because the center of center of geometry is going to be moving. So once you recognize that you have this phenomenon, then you're going to be more careful, because you know that you are prone to have foreshortening, particularly in systole. So these are some of the image acquisition recommendations, such as quiet respiration, image the ventricle at a minimum depth, maximize your borders, use contrast as required. You had a wonderful talk by Dr. Zogby the other day on contrast. But importantly is to have a way to bring that transducer way down, and that's why in an echo lab you have a big wedge cut in the mattress, so you can do that. But when you guys go to an ICU, that's not easy. So that's why in the portable studies we get back, that's where we're going to have a lot more issues with foreshortening because of the inability to go way down there into the left lateral and get a good alignment with the apex. For readers, when we're looking at echoes, the very first step for making a measurement of any chambers, but today we're talking of LV, but any chamber, is to select the appropriate image for that measurement to avoid foreshortening. And that's where having a technique that allows you to have multiple views at once is very helpful. You should not start measuring the first view. You should quickly scan all the views because you want to find that view that is less affected by foreshortening. And that is regardless of whether you're doing LV, RV, LA, or RA. So how big is this ventricle? We have multiple views, but that's about it, right? Good luck. But as Dr. Zogby showed you a few weeks ago, you put contrast and you turn the lights on. So this is a beautiful example of how contrast can truly turn around a study that was uninterpretable into one that is extremely interpretable. And not only can you stop this image at any place and trace and get volumes, but you can do wall motion. You can appreciate that there is obstruction, distal obstruction with a tiny, perhaps even a tiny little apex that may not be moving that well. So, contrast really has helped a lot. This is a heart that is not, this is not a bad image. In fact, this image allows you to stop, do some tracing, do some quantitation, and when that was done, the end diastolic volume was 200, EF was 36% in a patient with a cardiomyopathy. However, when contrast was given, you had much better delineation of the borders. The heart actually got bigger, and the EF dropped. And of course, that would be an important finding if you were trying to make decisions regarding ICDs and so on. And that's exactly what an old study published back in 2001 from Mayo Clinic showed very nicely, using CT as a gold standard. They showed that without contrast, there was a correlation, but look at the underestimation. An end diastolic volume of 200 was about 120 by 2D. But when contrast was given, not only was the correlation better, but now all the dots are more closer to the line of identity. The dotted line is the line of identity. And you can see that also in the Blunt-Allman. And we see that every day in the lab. When we use contrast, we frequently get bigger LV diastolic dimensions, which I encourage you guys. If you have an end diastolic dimension of 4.2 and contrast is 5.2, the 5.2 is the correct one. Don't report the 4.2. If you're given a contrast and you can see the difference, report the bigger dimension because that's the one that is going to be more accurate. All right, what about 3D? Well, 3D has been around now for quite some time. My goodness, I would say, what are you saying, Bill? 20 years or more? 3D has been around. Initially, it was this type of 3D where you were stitching several bits together and creating a format of the heart, and you get measurements. And this is an old study done back in 2008. It was important because it was a multi-center study. Everybody participating had been trained and they knew how to do 3D measurements. And actually, against CMR, by the way. So CMR was the gold standard and, good correlations overall. So for an R value, not too bad. However, again, an end diastolic volume of 330 was about 220 by 3D. So again, the same problem of consistent underestimation. Same thing for end systole. And then we go to EF, and the problem is where still 3D is a problem. Yes, you have a correlation, but individually, you get situations where you have a major discrepancy. Major discrepancy. By 3D in the 50s and 60s, by CMR in the 40s. I mean, that's too much for comfort. And the problem is on a patient by patient. Do you know if your patient is in one of these alignments or in one of these alignments? So on a patient by patient, and we see it in the lab quite often that we do the measurements and we get a number and then we do the 3D and it's very different. So On a patient by patient, it really requires even more expertise for the reader to be able to reconcile and either accept the 3D measurement or reject it. But if you're in a laboratory that is not too experienced and they think 3D is wonderful, they're going to throw in the number from 3D, which could be completely erroneous. And it's amazing that even with the newer techniques, because this is what we have now, we have the single bit assessment, which is a lot easier for the technicians, faster and accurate in a way. But we still have that problem. So this is the single bit technique, which allows you not only to measure the volumes, and in fact, these are one of several studies showing that there is a tighter fit. However, again, 200 by CMR, 150 by 2D. But a little closer spread with the EF. However, these were all very nice quality images. One beauty of this technique is that you can do actually volume, bit by bit analysis of volumes, which in a research environment could be very helpful. But let's go to real life. This is a case from our lab. We have lots of these every day. Image quality, good. Eyeball, what do you say? 60 or more, less than 60, but greater than 50 or less than 50? 60 or more, right? Everybody agrees? I mean, yeah, looks, all right. Measurements made, and notice again, using the new recommendations, so leaving all this stuff behind, okay? Because if we went like this, you would have an EF of 75%. So doing all this, actually 66%, stroke volume 77 by PW 75. We're happy, right? Reported, we're okay. 3D end-of-study volume 52, stroke volume 30, EF 59%. Obviously, the EF came a little closer, but everything else is just absolutely ridiculous, right? So that is one of the problems, that to this day, even having better 3D techniques, it really requires good image quality, number one, requires meticulous techniques by the technicians doing it, cannot be improved by using contrast, and again, we're left with having a number that we need to reconcile because we are not always sure, is that really accurate or not? Okay.
The issue with 3D is you cannot adjust so much for these calculations. You have to do it manually.
Exactly.
So you underestimate volume.
Right.
And then the EF may be close.
Right. So it is 3D, but it's 3D that requires meticulous knowledge of technicians doing this study because, yeah, you could do it post-processing using like a TomTech, but who has time for that? I mean, if you're in a research, maybe, but not when you're doing 120 echoes a day. So it really falls in the hands of the sonographer to have that level of sophistication to go through it, adjust everything to try to get the best possible number. All right, let's talk a little bit about speckle tracking. So what allows 3D speckle tracking, and we're not going to talk about it today because we still, it's still more theoretical, it's still more in research than everyday's practice, is AI. But all of these techniques, new techniques, are based on one important fact. Anybody can tell me what's the important fact that makes all of these things possible? If you're struggling to remember, think of your own TV at home. What is special about our TVs now at home compared to when Dr. Zogby and I were in high school? Huh? Digital, exactly. If it were not for a digital matrix, none of these things would be possible. There would be no 3D, there would be no automatic measurements, there would be no speckle tracking. It was, the good old TV that we had in the old days. So digital matrix is what made it possible to have all of this stuff, okay? So with speckle tracking, what's happening is that you have a digital matrix, okay, and you have pixels. And the system was taught to pick up one little pixel and follow the movement of that pixel through time. So if you can follow these pixels through time, but you also can follow this one through time, you can measure the distance between the two of them from diastole to systole. And if you do that, with a lot of pixels around the heart, you can then get this shortening of the formation of the muscle from diastole to systole in several vectors, because the fibers are deforming in more than one vector. And in fact, that's what it is, right? You have now radial strain, which is deformation towards the center of the cavity. In essence, is the same thing as talking about wall thickening. And that's why it's a positive curve as the wall thickens from diastole to systole. Circumferential strain then is in the short axis also, but the vector now is along the circumference of the heart. So it is a negative curve along the circumference of the heart. And then longitudinal, which is also along the circumference of the LV, but in a longitudinal view, and likewise, it is a negative curve. So all three are there, all three are available. There has been a lot more research with findings that are applicable to clinical practice with the longitudinal compared to the circumferential, in part related to the way the heart, the fibers in the heart are oriented and contraction occurs. So I'm not going to cover too much of radial circumferential, not because simply they are still looking for a disease to provide data for, whereas longitudinal strain already has a good record of findings that we'll be showing, okay? So we have a 4-chamber view, and there are multiple points where you are doing the strain analysis. This is a nice presentation that shows you basically the symmetry of contraction, because you start in diastole, you get to end systole, and then diastole again. And if everything is relatively symmetric, then you have this nice distribution of colors, okay? It's just a simple qualitative thing that we rarely use anymore, but it's there and we look at it. The curves are very helpful because you see that all these curves are trailing together. Because it's a negative curve, strain has been reported as a negative value. However, if you do a volume curve in a ventricle from end diastole to end systole and back to end diastole, guess what? It is also a negative curve, because the heart ejects and goes from being big to being smaller. Does anybody talk of an ejection fraction of minus 65%? We should. In theory, that would be the mathematically correct expression, would be minus, because it lost a certain amount of volume. You would be declared crazy if you did that, right? Okay, so same thing happens here. People have put in a minus sign, but it creates confusion because a minus 14 would be considered better because it's more positive, but of course, from a function point of view, it's not. So let's just drop that, right, and talk about absolute values. So what happens here then is that you do the 4-chamber, the 2-chamber, and the apical long axis. That creates strain through all the different segments of the heart. You can see this nice, beautiful color expression, which you could print and put in your wall as an abstract of modern painting. But what we all tend to look at is at the bullseye. The bullseye gives us sort of a nice demonstration, and then colors are used to provide the different ranges of strain. In contrast, this is a cardiomyopathy, non-ischemic cardiomyopathy, but still having a fair amount of regionality in deformation or contraction. You can see that very nicely here because this is all broken away. But to me, I see it even better here because you can see that this is hypokinetic, and this is practically dyskinetic, and here is almost akinetic. So we have segments with different forms of strain. The global is the average of everything. And remember, what we are reporting is the peak. So the true statement is average peak global longitudinal strain is X. Because all we are reporting with the bullseye is this number here, is the peak negative value. And we are dropping the negative, at least I drop it. Okay, so what's normal? So there's been all kinds of studies. This is a nice paper because it's a meta-analysis over 2,000. Here are all the authors presenting. And these are all the values presented. And I created that little line here because you can see it doesn't matter which paper you read. If you are at less than 16, clearly you belong to the wrong side of the track, okay? And interesting finding when they did the meta-analysis that looking at age distribution, some old folks are having a little lower value than the younger people, but still better than 16. And when they look at different companies, vendors, there were interesting findings. Tomtec had the highest values. These were, followed by GE, Philips, and then Siemens. Oh, Toshiba, and then Siemens. But regardless of vendors, 16 was still the absolute marker between normality and abnormality. So what the recommendations have been, which we follow in the lab, is over 17 is normal. 16 to 17, we use this low normal term because it could be low normal, maybe it is marginal abnormal, but we use this low normal terminology. Below 16 is clearly reduced or abnormal. So the beauty of strain is that because it's looking at myocardial deformation or shortening, it's more accurate than EF in assessing left ventricular function. So it can detect subclinical dysfunction in patients where the EF appears to be okay. It gives us an objective number that we can use for both regional and global function. As I'll show you, there's increasing data coming in terms of its power to predict cardiovascular outcome. And then there's some regional patterns that are kind of nice because it's a simple eyeball of the bullseye that can give you a quick suspicion of the different type of diseases. Now, it's important to remember that this is still is a shortening, deformation shortening functional measurement. And you may not know this, but one of my very first papers when I was a fellow in 1973 talked about the loading effect of shortening measurements in those days using good old end mode. And even in those days, we showed very nicely, all these parameters are load, they are affected by load, particularly afterload, but also preload. And that might explain some of the findings that we'll show later. So high afterload can lower your measurements. And that's why if you look at some of these papers that were written for normal values, they recommend having an eye on blood pressure because a person with a 180 systolic at the time of the echo could potentially have a lower value than perhaps if the blood pressure was 120. So, it's not a bad idea to kind of keep an eye at that blood pressure. So here we have one of those examples. This is a hypertensive end-stage renal guy with an EF of 90%. I mean, this is cavity obliteration. And yet, the peak global strain average 14.2, clearly reduced, with some areas being even worse than others. And this is not CAD because it's not following nicely a coronary distribution. So this is where the power of this technique is. And now actually there are current studies going on in looking at how GLS can help do better prediction of outcome in end-stage renal disease, and which may actually eventually lead toward trying to be more aggressive with transplant and whatnot as work in progress. So the bottom line is that there's a whole list of conditions where subclinical dysfunction is being detected by strain: hypertension, hypertrophic cardiomyopathy, diabetics, transplant rejection, chemotherapy, valvular lesions, end-stage renal, sepsis, and of course, HFpEF, very important because HFpEF, by definition, has normal ejection fraction. The list is growing. And clinical outcomes, as I'll show you, overall tend to be worse when strain is reduced. So let's talk about a little bit about the breast cancer because that was one of the first areas where there was a lot of excitement. And the fact is that after a lot of studies and looking at meta-analysis and whatnot, if you drop in serial assessment when patients are taking cardiotoxic medications, a drop between 10-15% has a prediction for a fall in EF of 5% or more. That's the good news. The bad news, and actually even absolute values also can be predictive. If somebody has not had a baseline, but now they're on therapy and the absolute value is, let's say, 16 or 14 or 15, that by itself also has prediction. And even the baseline value, somebody starts already with a reduced GLS, they do have a higher potential for developing cardiotoxicity when the drugs are given. So all of those things are true. The problem is the accuracy. And the biggest problem is this specificity. So you may have a drop in GLS, there's some sensitivity, but the specificity may not be there. And for that reason, still most experts are still relying more on EF. So the GLS, they pay attention to the GLS, but if you're making important decisions of adding new therapy or maybe holding back on chemo or whatever, the EF still continues to be the preferred parameter. So again, more studies needed, stay tuned, but it still has not crossed that barrier, that cross of being the gold standard that is used for making decisions in every patient in terms of introducing beta blockers and ACE inhibitors or reducing the dose of the chemotherapy and so on. This is the important part here. We've known, of course, that the outcome of patients with heart failure varies a lot, and EF is not the best predictor, and people with HFpEF can have as bad a prognosis as people with HFrEF. So in this range of EF, the outcomes are all over the place. And in fact, that was shown beautifully in this paper by Park with over 4,000 patients hospitalized for heart failure. So look at the density of distribution of EF, a very nice distribution. So in fact, about half of the patients were over 40-45%, and half were under. So very nice distribution of EF, and sure enough, no surprise, not a very strong signal in terms of EF itself as a predictor of outcome, but the signal for GLS was incredible. Starting somewhere around 12, it takes off like a rocket in terms of prediction of death, which is a very definitive outcome. This is a more recent paper last year in over 300 patients with dilated cardiomyopathy. They all have been treated with guideline recommended therapy, and they were in the quote unquote clinical stable mode. You have given all the therapy, they were outpatients, they were class 2 or sometimes class 1. So at that point in time, they look at the strain and EF. Best outcome in close to 10 years, so obviously this was a retrospective study, in close to 10 years, best outcome was EF over 40, GLS over 13. Worst outcome, EF less than 40, GLS less than 13. But look at this. So if you had a better EF than 40, but your GLS was less than 13, that outcome was just as bad as having the low EF. So again, introducing the power of the GLS. Now we switch gears to valvular disease, aortic stenosis. And in this study, they showed that under 18, which is interesting, a little different threshold because we still talk about 17 being relatively normal, under 18 having a greater index of symptom developments over 5 to 6 years, and or time to intervention in terms of valve replacement. But this is even a more interesting paper. This is published very, very recently. I'm trying to see if I have the date, but I think this is at 2023. 760 patients with moderate aortic stenosis. In other words, peak velocity less than 4, mean gradient less than 40, valve areas usually were 1 or better. Okay? Follow for 50 months. Endpoint mortality. Simple endpoint. Nobody can argue with that one. EF greater than 50, GLS better than 16, the best curve. EF less than 50 or greater than 50 with a GLS that was less than 16, different, much worse curves. These people didn't have severe AS. They were moderate. But this is even more interesting. There was a subgroup of 385 completely asymptomatic, happy patients. And again, look at the discrimination of strain in terms of using 16 as the cutoff for simple, straightforward death. So this is now the hazard ratio analysis, seeing again 16 roughly being the cutoff and then increasing risk as the GLS worsens. Now, these people, I'm sure, had all kinds of combinations. These people had hypertension, elderly. I mean, there's a mixture of things here. This is not just aortic stenosis by itself. The point, however, is the power of GLS in predicting outcome. Now, what we don't know, because the study have not been done, if you took that patient with a GLS of 15 and replaced the valve, are you going to change that curve? Or is that GLS already abnormal because they also have hypertension and diabetes or whatever? So obviously, the fact that we can see this type of analysis doesn't mean if we intervene, it's going to change. That study needs to be done, okay? Which is what I say here. Okay, now, mitral regurg, same story, but notice the cutoff. Completely within normal range. Well, with EF, it's the same story, right? Less than 60 is trouble for mitral regurg. So again, it's a lesion that has a high preload component, lower afterload because of the leak in the mitral valve, and we use higher threshold for EF, and lo and behold, higher threshold for GLS. But less than 21, looking straightforward at death, over 12 years, quite significant difference compared to the one that have better than 21. This is another paper. In this paper, what they follow people after valve replacement or valve repair, okay? And in general, EF tends to drop when we fix the mitral regurg. But what they saw here is that people that have a GLS of 18 or better, they dropped and recover. So they went from a 63 average to about a 54, but then they gradually went back to a 58 or so. But those with a lower GLS went down even further, and although recovered, they still remain subnormal. So the hit was worse in the patients with a lower GLS. And then looking at cardiac events and all-cause death over 100+ months, so this is a long follow-up. Again, GLS better than 18, much better survival than under 18 for cardiac events and for all-cause death. So I think that eventually we're going to see an impact of these findings in guidelines. We'll have to see whether they will require a trial where GLS is used for treatment or not. But I think these findings are powerful enough that we have to pay attention to. And then recent paper I picked up last month or so, it's patient with simple sepsis, which is a bad disease. And we know sepsis affects the heart. We see that quite often. People with sepsis sometimes have drop in EF and then they get better when they survive and they improve. But what they found here is, likewise, in a small study, and you can see the sample size, 73 with normal GLS and 51 with abnormal, but still an impact on survival in this group of patients with sepsis, which is a disease that is really systemic but has cardiac involvement. Finally, this is the cute part. This is what we do every day in the lab. It's kind of fun because we just simply take a quick look at a bullseye, and if we like the image quality, and we trust the bullseye, we can see all kinds of nice things. This is a patient that has an EF of 38%, but clearly has diffuse hypo, but have a big area here of akinesis in an RCA territory, and that shows very nicely in the strain, but actually shows even way going into the circumflex region. So it's either a very dominant right or circumflex. And again, the global strain is quite reduced. It's in that range where outcome might not be that great. This is even a nicer case because there's some foreshortening here. EF looks normal to the eyeball. You're suspicious this area may be abnormal, but sure enough, it shows very nicely in the strain. And again, the global strain is already on a relatively reduced level. That, just looking at the 2D findings, one might not have expected that. And this is kind of an interesting case. A patient of mine, this is the EKG. It's one of those EKGs read as possible all anterior MI because of the reduced R-wave progression. We see that every day in our clinics, patients coming like that. Is this because of lead placement or not, or what's going on? So that's the EKG. That's the 2D echo, where we have a little trouble seeing very well the apex. And that's the strain. And the strain shows this area here of reduced value, particularly this dense area here of very low values, where everything else is pretty decent. In fact, the average peak GLS is 17.6, which is in the normal range. So contrast is given, and sure enough, nice little tip of the apex there, akinetic. So a little tip off coming from the strain, say, let's do some contrast, shows very nicely. Now, we all are familiar with this one, the amyloid cases with the apical sparring. I think everybody by now is sort of an expert at this one. Remember, apical sparing means apex, because there are many other cases where you see, low values here, and then a much bigger, wider area of orange-red. And we see that often with hypertensive and whatnot. That's not apical sparing. Apical sparing is right there. It's this region right there, okay? And of course, you see that together with other findings. It's, again, not one thing that by itself is going to give you a diagnosis, but certainly suspicious enough that we mention it in our reports. Nice little case where, again, the 2D echo might be suspicious of something at the apex. Again, we have this dense area of very low values, but even the global is kind of reduced. So if this is coronary artery disease with maybe an old apical infarct, it looks like you have a great EF here. Why is the global so low? That's just, it's a little worrisome. Well, there's your answer. When contrast is given, this is somebody that has, of course, the apical variants of ACM. But again, the little tip of the apex being very abnormal by strain is a tip-off that something else is going on. Contrast is given, beautiful contrast, very good agreement with the CMR. So where are we now? Well, clearly we're detecting subclinical dysfunction in a lot of different diseases. Clearly the data shows that longitudinal strain can be a good predictor of serious cardiovascular outcomes and can be better than ejection fraction. It gives us a number, an objective finding, both for global and regional. And then there's some regional patterns that can be associated with either ischemic disease or different types of myocardial diseases. Limitations, well, you still need a decent quality image. Contrast is a problem. If you give it, most machines don't know how to handle it. Again, as I mentioned before, it's affected by loading, so keep loading in mind, and that's probably why with mitral regurg, the threshold is higher than with other diseases. Just like with 3D, if you have an inaccurate result, it could be incorrectly accepted. So the biggest question is you have a perfectly normal 2D. Everything looks great. The diastolic function, everything. It looks just absolutely pristine. Strain comes back 14.7. Do we report it? Do we hide it? Do we put it under the table? Do we say it was difficult to measure? Well, actually it wasn't. It looks pretty good there. In part because, even as a doctor, what the heck would you do with that information? Now, if it's a hypertensive, maybe you'll say, okay, I'll treat the blood pressure more aggressively. But it's just tough to decide what to do with just one number when everything else looks good. So I don't think we have an answer for that one. I can tell you, sometimes I do put it under the table, and I don't report it. because I'm going to create also a confusion on the other side, on the other side of the person receiving the report. What are they going to do? So that still is an issue that we don't have a clear answer for. But certainly when we're dealing with people that do have diseases, HFpEF, valvular diseases, the data now is quite strong to say that the strain is a better predictor of outcomes. And therefore, I think we will, in the next few years, start seeing these penetrate guidelines. I wouldn't be surprised if we're going to see some recommendations in the guidelines, particularly for valvular heart disease, but even perhaps for even HFpEF. I mean, if you have somebody with a strain of 9, 10 in a HFpEF patient, maybe we need to do some sort of, and now that we have so many other forms of treatment, it might be potentially an important finding. So thank you very much, and we have a couple of minutes for questions. Comments, jokes? Yes, sir.
So, in terms of correlating the...
Do we have a mic? Do we have a mic that we can give him? No? Okay. Shoot.
I'll speak up. So, in terms of correlating the LV, the diastolic volume index, between echo and, for example, MRI, the upper limit for echo is significantly lower. Like, it's up to 75.
That is correct. That's a great question, by the way. If the question is, what is the upper limit of normal for LV diastolic volume, echo, CMR, and whatnot, the first assessment of volume was biplane angiography. Nobody does that these days. The numbers there were closer to MRI, much closer. So an end diastolic volume of 95, even 100, would be upper limit of index would be considered normal in a male, where in the 2D recommendation would already be enlarged. Problem is, those 2D numbers came out without contrast. So I tell you what I do. If I use contrast, I use more closer to the CMR thresholds, because we have shown that contrast bring the curves closer to the line of identity with CMR. If I'm just doing regular 2D, no contrast, then I'll stick with the numbers published. Now, I'm doing that in part because I'm coming from a 40-year tradition of learning all this from the days of angiography to everything we have today. It's a problem because since we're using more and more contrast, it can create an overcall. In other words, if you have an diastolic volume index, let's say of 87, if you use the table recommendation, that will be considered enlarged. So it is a problem, and we have not resolved it yet. It's a good news, bad news with contrast. So that's what I do. If I use contrast, in my mind, I'm using more of the CMR values. If I'm using regular 2D, then I use the standard. But I'm not saying that that's the best way to do it either. Good question.
So there's no published normal value?
With contrast. I am not aware of it. Bill, are you? I'm not aware of a normal standard values for volumes with contrast. I don't think anybody has done it. Maybe we should. It's a simple study. I don't know. Yeah, no, there's not. Yeah.
Dr. Q, I have a question.
Yeah.
What's the utility of global circumferential strain or radial? And if we can incorporate with longitudinal strain?
So the heart, as you know, the heart has, the fibers are oriented like this, crossover like this.
Yeah.
So when you squeeze, you get a much better circumferential vector than longitudinal. So the problem with the radial and circumferential is that they have tended to follow more the EF. So you have diseases where EF is normal, while the circumferential strain tends to be also kind of normal. Longitudinal could be lousy. So that's why initially I said both radial and circumferential are looking for a disease where they can help. And in part it is because the values tend to be tracking closer to EF, because he has this vector of contraction. Clearly, that's the strongest vector of contraction in the heart is this one. It's not this one. Yeah.
In a way, we can incorporate with GLS and kind of do a underlying value, would that perhaps increase the specificity of GLS that we sometimes?
I have no idea. You want to look into that? Go for it. That's what you're here for. Find a passion and go into it. Extreme BSA. Yeah. No solution. That's why people have been, for several years now, pushing height. Because we have these enormous people, 5'4", 300 pounds. So the BSA comes out very high, but it's because of all the obesity. And the question is that really fair? And that discussion, believe me, has been taking place now for more than a decade. And a lot of experts trying to push for height being better, but still, it has not quite penetrated the day-to-day use. Yeah. Yeah. It's, again, another very good question. Well, actually, we could. In fact, for mass, when we do mass, it gives us automatically, the system we have gives us the BSA correction and the height correction. We could, yeah. Problem is, again, most clinicians won't even know what to do with that. The number, it's not a number that people are kind of familiar with. So, it's, you would have to report it and then have a comment next week so that you could train the, yeah, if they're discrepant, yeah. How do you manage it? No, normal. In fact, it's one of the nice ways of differentiating pathologic hypertrophy from athlete hypertrophy. Yeah, no, it's normal.
Using that same cutoff of 16%?
Well, remember, most athletes are young people, so most of them are going to be in an 18 or better. Yeah. I am not familiar with a study with athletes knowing exactly the spread, but in general, it's normal. Yeah. And in fact, it would be something that if you are seeing a patient for the possibility of being true LVH versus athlete, is one of the things that is recommended is to look at GLS. The study function and GLS being two things that can help you differentiate the athlete from the pathologic hypertrophy.
So there's some vendors, specifically I think Philips, which actually give relief from strain.
That what now?
They give an ejection fraction from strain. Is there any studies now? Is there something that we can do that we should do?
Okay, so there are some manipulations of the curve that can potentially give you an EF. Personally, I have not tested any of them, so I defer an opinion on it. So I don't know. I don't know if we can trust them.
Based on the current data, how good is myocardial power to overcome the loading potential?
How good is what?
Myocardial power?
Myocardial power. You must be interested in research. Yeah, I know. Listen, ever since I was a fellow, we have been looking for the magic number for myocardial contractility, and that's 50 years, and we're still looking. So yeah, it's one of these parameters that involve shortening plus the strength, the force with the blood pressure and whatnot. It's just one more parameter. That's what I can tell you. It's not the panacea. Yeah. And again, the more complicated you become in having to make measurements and calculations and whatever, you know you're not going to have something that will be used by the average doctor in practice. I mean, that's just reality. That's why EF has been so popular, because it's so simple, just oh yeah. All right, I have to run to the doctor. Thank you.